I'm happy to see a lot of familiar faces around the room, and I'll try and make this as pleasurable as possible. But remember, we're talking about regulations, about laws, so it's not always a fun thing, but I'll try my best. Would like to acknowledge Mallinckrodt is the company that makes Methadose, which is the product that's going to be commercially available for us. They have provided the college with an educational grant, which made it possible for us to make those live sessions and come out and see you guys. One of the things that I want to establish here tonight is that the college did not come to any of the decisions we made regarding the Methadose or the changes to the policy and things that we've tweaked in the policy by ourselves. We have been talking to the other College of Physicians and Surgeons. We've been talking to pharmacists, talking to advocacy groups, and everybody came up with important points. And if you remember last year, I also came out and had presentation with you guys, and we got questions out, which were directed towards issues that you're facing in the practice. So all these things were a reason for us to open up the guide and the policy and do the whole revision. So I want to acknowledge all these people that participated in all this process. There was a group of pharmacists that got together as well as the experts in methadone dispensing, and they were the ones that guided us through putting this guide together. We've got plenty to talk about tonight. I'm not going to talk about everything that we talked about in the last 2 years. I'm going to touch on a few things that are important for the night. However, you're still responsible to go back and review everything. So the agenda, basically, we're going to talk about why we're here. We're going to talk about why BC is making that change. We'll talk about the whole revised policy and things that we've changed in the policy. As always, the way we look at methadone is the whole administration of the program. When you take the prescription in, what is it that you need to do with it? How you think when you're revising the prescription, making sure that, reviewing the prescription to make sure that everything is complete. You process the prescription, you prepare the product, and how you dose the patient. And we'll talk about some issues that could relate to continuity of care. At the end, we're going to have a summary and a few frequently asked questions that, believe it or not, we're still getting calls about. So I just want to make sure that we address those questions and make sure that we put an end to those once and for all. So why is BC making this change? Because we're going now to the new standards of 10 milligram per mil. We'll talk about the policy. Like I said before, various working groups identified issues, and it was time for us to revise those things. And we're also going to talk about a new policy, Professional Practice Policy 71, which puts some guidelines around methadone deliveries and the prohibitions of methadone delivery. So the board of the College of Pharmacists on September 20th exactly approved the change, and to make that, now they've mandated that pharmacists, pharmacy staff, and pharmacist staff, relief pharmacists, and regulated pharmacy technicians employed in a community pharmacy that provides methadone must attend this training, because at the end of the day, the change in concentration is a significant thing. So we want to make sure that we transition into the new practice safely as possible, because we want to make sure that we ensure public safety. Now, before I tell you why BC is making this change, I need to give you some legislative background. As you know, methadone is ultimately a controlled substance, which puts it under Health Canada's jurisdiction. So it's a federal legislation. But when when the legislation between the feds and the province come together, or there is a crossover, we as a province can regulate, we can over-regulate, but we cannot under-regulate any federal requirements. So, over 30 years ago, the feds set the first requirements for methadone dispensing, which is what we've been doing all these years. But the truth is that BC was the only one that went and had the 1 milligram per mil, because the feds in the requirements had said that methadone has to be dispensed in a crystalline juice to minimize the chances of divergent injection and so on. We were the only province that had the 1 milligram per mil. Other provinces, and anybody who's worked in Ontario can attest to what I'm saying, they work with a concentrate. So the pharmacy chooses which concentrate they want to use, 2, 5, 10 milligram, and they use that as long as they top it up with juice. So in late 2012, Methadose, which is the commercial name for methadone 10 milligram per mil, received an approval, which is what we call the notice of compliance, to be sold in Canada. So like any other product that you have on your shelves, to be sold in Canada, it has to be approved through this process of notice of compliance. The college does not get involved in any of this, what product gets approved. The company that makes Methadose made a submission to Pharmacare as well, and Pharmacare has indicated that they are intending to cover it as of February 1st. Once you put those two pieces together, here's where the colleges come in, because the college's job is to set the standards of practice. And because methadone has a set of standards that everybody has to follow, this is why we're here tonight. So you will not see me here talking to you about approved prednisone or any of those things, because those things just happen and the colleges don't get involved. The only time we got involved is because of the set of the standards that we have to talk about. If you just forget for a minute the fact that Methadose is 10 milligram per mil, the significant change in concentration from what we're used to, look at the list of pros of this product. So this product is standardized, it's manufactured, it's under good manufacturing processes, it's tested, so it goes through quality control. It's consistent to patients. We're not going to have patients running around saying this pharmacy doesn't make it the same or it doesn't taste the same and so on and so forth. And trust me, we hear that often. There will be no compounding anymore, so we're eliminating a big chunk of potential error at the end of compounding. It does not need to be kept in the fridge. And it's a much smaller quantity, because now with the concentration being 10 times the strength, it's going to be much less in milliliters that you'd have to measure. It is made in a hypervolemic form, so it is not, according to the literature, injectable. And we're hoping, again, those are the other agencies that are working on those things, we're hoping that PharmaNet, when we have a DIN for Methadose, that they will be able to turn on the DUEs for us. So then you would get all the clinical information that you get when you're processing other prescriptions, versus now you're working on pins. Now, everything has a pros, must have something too in the other list. The truth is, it's a significant change in concentration. So one mistake can be really serious. The other thing is that it looks a lot like Tylenol Children's. So the Children Tylenol is cherry flavor, and it looks a lot like the Methadose commercial. The other thing is, to be able to dispense such small quantities, pharmacies will have to make changes to how they manage the program. So you will have to change the device you use for measuring. I know everybody can do conversions. However, I just wanted to give you guys a visual of how much less the patients will be getting. And as a pharmacist to pharmacist, I have to tell you that we all have moments of where our brains freeze kind of thing. I know that my weakness was my first half an hour of my shift. I knew that this was the highest chance for me to make a mistake, and I was very aware of it, so I always made sure that I was even more focused in my shift. Why I'm saying this is because I want you, each one of you, to set some safety parameters in the back of your mind when it's time to dispense methadose. You need to put some parameters of where am I going to catch myself and stop if I'm measuring too much. Because remember, if you give a patient who's supposed to get 100 milligrams of methadone, we used to give him 100 mils. If you give him 100 mils of methadose, it's a liter of what you're making now. So you put your own parameters. If I find myself measuring more than 10 mils, do I stop and think? Because 10 mils is 100 milligrams. I'm not going to tell you. I'm just giving you suggestions. And of course, we're equal pharmacists. You can make your own decisions. Again, remember, the impact of a mistake could be very serious. Here's the children's Tylenol. And here's what methadose is going to look like. You see how similar those things are. So we're going to have to educate our patients about safety, about how they safely store their methadone when it comes to the methadose. It's going to take some work on our part, but I'm sure we will, at the end, we will be ahead. Now, to make it easy on everybody, at your tables you'll find a copy of the guide, the new guide, and some sheets that contain all the changes that have been made from the 2011 copy. So I'd ask for you to have both of them handy so you can follow through this presentation. Here's the first change, Appendix 1, page 18, which addresses the change in concentration. So this change was approved on September 20th, as I said, 2013. What are the requirements? As of February 1st, 2014, everybody, pharmacy managers, pharmacy staff, relief, and regulated pharmacy technicians that work in a community pharmacy must know the guide and apply the principles of our policy and guide. The College of Physicians and Surgeons is working on their own guide as well, so you would be required to know about that. You need to complete the session, which you are here tonight. However, anybody who's not going to make it, they're going to be watching this recording. And here's another change. In the past, we had asked you to sign a declaration and keep a copy in the pharmacy. Here's another change now. As soon as you complete all the requirements, you need to log on e-services. How many of you know their e-service password? Good for you. I never know mine. I actually have somebody ask them to change it for me every time. You log in your e-services, click on My Declarations, check the box that you're declaring that you have taken either the live or the online. Pick the session that you've participated in, and you're ready to go. And I ask you to do this as soon as you can, as soon as everything is available, the College of Physicians have completed their guide and everything is in place, because eventually the college will be pulling reports to compare who's been trained versus who's been processing methadone prescriptions. So there are no surprises there. So as of February 1st, 2014, so we are giving 1 month of transition. So pay attention here. As of February 1st, methadose, according to PharmaCare, is going to be covered. However, because we recognize that there will be active methadone prescriptions in the pharmacy and you still have some methadone stock, we are going to let both products run for 1 month. You're going to be able to dispense the methadone 1 milligram per mil that you've compounded. However, you will also have the methadose 10 milligram per mil. Why? Because as of February 1st, any new prescription that comes in must be at the 10 milligram per mil. So through this presentation, we're going to also see a new prescription form that the physicians will be using exclusively for methadone for maintenance. What's the purpose of the change? I think everybody can imagine that we're hoping that patients will get a more standardized methadone treatment, that we're reducing the risk. If we get through or over the measuring issue, hopefully that the patients will have reduced risk, because inconsistencies in methadone I don't think is news to anybody. Now, here's another part. A patient must, as of February 1st, patients must attend the pharmacy unless exceptional circumstances are provided for under the Professional Practice Policy 71, the delivery of methadone. What does this mean? The college has never mandated how many hours a pharmacy should be open. But now with the new policy, Policy 71, coming in place, some pharmacies will have to reconsider their hours. If you remember, in the beginning I talked about methadone ultimately being a controlled substance, so it's under Health Canada, which makes Health Canada the upper hand in the decision in how they can regulate any requirements around it. Federally, methadone delivery is prohibited. That's always been around. This is not news. The fact is, transportation of methadone can only be done by what they call a licensed dealer, somebody who's got an establishment license. We pharmacists do not have an establishment license unless you have a wholesaler license. But as a pharmacist, we're not, or pharmacy technicians, we're not supposed to be delivering. Again, I don't think it's news to any of you of what's happening out there with deliveries. So this issue has been brought to the colleges, to the municipalities, to the police, issues with deliveries going around, what the problems with deliveries. So the colleges had to take a stand and at least match the federal regulations. But being a college and being a body that makes sure that wants to make sure that patients also get continuity of care, we've still left a very small room of how deliveries could be done. So this policy has been approved actually since June of 2013, but has not been enforced yet, and it will be in place as of February 1st, along with everything else. So under extraordinary circumstances, and only if the patient has severe restrictions in mobility, would the physician sign a declaration that would allow the pharmacy to deliver the methadone to the patient. This is only the exception to the rule and is not the normal practice. Pharmacy staff, pharmacist, pharmacy manager, nobody can alter that after it leaves the physician's office. So if halfway through a patient has an accident and they're immobile and they cannot make it to the pharmacy, a new prescription must be issued. If a pharmacy delivers, then they need to set those 5 standards in place. First, they must have the prescriber's authorization to deliver. They also have to make sure that their delivery will fit within their business. If they do not deliver, this policy doesn't say you must deliver. If you cannot deliver and you get a prescription that is signed that the patient will need it delivered, you just have to refer the patient to another pharmacy. Security and transportation, I don't think, again, this is news. So security is an issue that pharmacy managers and pharmacists would have to take very seriously. And at the time of release of methadone, all the rules that apply to witnessing a methadone dose apply no matter where you are, and the documentation is exactly the same. Now, prescribing, I told you that there will be a new prescription form, and here's one of the sections in that new prescription form that will say that due to the patient's immobility, I confirm delivery is required, and the physicians would have to sign that. Now, if you are concerned that this could be an altered prescription or something happened in its way to the pharmacy, you are obligated to verify the authenticity. Physicians will make sure that it's safe for the patient to get a delivery. They will not authorize a delivery unless they have established all these things. And distance between pharmacies does not qualify as a restriction in mobility. So pharmacies in North Vancouver don't need to really go deliver downtown, and pharmacies out in Abbotsford don't need to come out to North Vancouver. I think we've got enough pharmacies out there. Now, home delivery schedule and location. Like I said, the pharmacy needs to make sure that it fits within their schedule and it is part of their business that they will deliver. Otherwise, they just refer the patient to a pharmacy that does. If the pharmacy is able to provide delivery to the patient's home, do you know why the pharmacist has to deliver to the patient's home? Because if the patient is not immobile and is going to meet you at the SkyTrain, then he doesn't need a delivery. Security. The dispensing pharmacist is responsible for the security and the securely transportation of the methadone. So all the parameters of safely transporting the methadone are ultimately the pharmacist and the pharmacy manager's responsibility. But every pharmacist on duty is a manager. Directly from the pharmacy of origin to the patient. No stops. The release of methadone for maintenance. Now, I don't know if you noticed, but the must is in capital in red and it's underlined. So the pharmacist, and only the pharmacist, must be present and witness. And the word witnessing methadone is a loaded word. It's not witnessing as in staring the patient down while they're drinking. Witnessing methadone is the clinical component that as pharmacists we're responsible for. You as a pharmacist, as a clinician, you have an obligation in which you need to live up to. So witnessing means you assess the patient. You make sure that this patient is ready to get their dose. They're not intoxicated, they're not on something else. And I understand that it's not something easy, but if you're in practice and you see those patients every day, you definitely can establish some baselines for behavior. We all see the same patients day in and day out. Now, documentation, you have to document that you witness the patient, and the patient has to sign, of course, for receiving their dose. There will be only one form for methadone for maintenance. And I ask you that as of February 1st, that you stand your grounds and you make sure that only methadone for maintenance form is accepted. And you need to train others as well. We need to make sure that we stick with the new form because the new form is designed for the 10 milligram per mil. It's going to make everybody's life much easier and it's going to cut down on a lot of errors. So let's talk about those forms. Here's the old form that everybody knows. And here's the new one. From where you are, probably they both look the same, but they don't. There are some similarities, but they're different. So let's take them one section at a time. The old prescription had methadone 1 milligram per mil and crystalline juice for maintenance, and it said no home delivery. We all know where no home delivery went from there. Void if altered. Again, that's an interesting part that in the new form, it does not exist anymore. So the new form in that very same section, there's only methadone 10 milligram per mil. Now, apparently the void if altered was very confusing to physicians and pharmacists, so it has been removed. And the College of Physicians is committed to communicating with the registrants that they will treat those forms like they treat checks. If they make a mistake, they will initial it, but they are responsible that if they make too many mistakes and it's starting to look messy, that they start over. And again, if you come across any issues and you can't really get the physicians to cooperate, the college will be more than happy to help. Now, there is a section in the old prescription that said no refills permitted, void after 5 days unless it's for methadone, which honestly, in all my years, I could not understand this part. I mean, it says void unless it's for methadone. What is for methadone? So I don't know what they were thinking putting this thing in. But this is now a very nice space for physicians to write any special instructions. So then they don't have to be writing at the edges of the prescriptions. So now there is space for them where if they want to write to you any instructions, they will be nice and clean and neat down there. This is the part that has to do with Policy 71, where the physicians must sign for delivery if the patient has mobility restriction. This part stays the same. The reason I have this in because I still have questions about prescribing date versus start date. So let's put this one out once and for all. The prescribing date, the far right corner, top corner of the prescription, is for the day the physician saw the patient. If this prescription is intended to start at a future date, that goes in the body of the prescription. If there is no other date in the body of the prescription, then the prescribing date is your start date. And we're going to address this again. This is the methadone 10 milligram per mil. This is the Policy 71 with delivery. I ask you, when you get any prescription, any methadone prescription in, as soon as you get it in, deal with any discrepancies in that prescription as soon as you get it. Because once you commit to it and you start it, it's hard to deal with issues. So if there's any discrepancy on the prescription, deal with it the moment you get it. Make sure that the math adds up, the quantity adds up with the dates of the prescription, and so on. The dose can be divided by the total quantity. Here's the start date and the end date. And again, if there is no start date on the prescription, the start date is the prescribing. Now, always remember that ultimately the methadone program is a harm reduction program. So that means that your default is always to think about how can I reduce the harm to the public? How do I reduce the amount of methadone on the streets? So if the physician does not circle daily witness or carries, then you automatically, your default is to fall back on daily witness until further information. You hold back. You don't go out and just say, well, the previous prescription was for carries, go for it, man. No, you pull back until you're clear on what you need to do. This is where the physician signs for the prescription, the area with the special instructions. This is the pre-printed part where the physician's information is on the prescription. And here's another part. So in the past, we had said that the patient could sign for the first dose on the prescription or on the daily dispense log. Well, apparently that has caused some confusions. So we're retracting that. And as soon as you can, you have to start this. As soon as you can is tomorrow morning, basically. The patients have to sign the bottom of the prescription for their first dose. So, clear? Good. Now, remember the old prescription had void if altered, and that was taken out. So let's address the void if altered that has been taken out. What kind of alterations are we accepting? In my mind, there are two sets of alterations. There is an alteration where the physician makes a mistake in the clinic, so he just crosses it out and initials. But there's also the part of alteration that you may have to do if you get a prescription and there is something that needs to be corrected or modified. How do we handle either one of those? So physicians will be instructed that they can only alter any parts they write. Any part in the prescription, the new prescription form they write, they can definitely make an alteration there. But anything pre-printed on the prescription itself cannot be altered. So They cannot cross out methadone 10 milligram per mil and decide, no, I want my patient to get 5. No. They cannot change anything that is pre-printed. Now, from your end as a pharmacist, if you get something and it needs to be addressed because there is a discrepancy, it's the old system that we had that you all know about. You fill the pharmacist-prescriber communication, you send it to the physician, you get the authorization signed, and you file that along with the prescription.